Hello and welcome again to the Emergency Medicine Clinics podcast. I'm Patrick Manley, the manager of the Clinics program here at Elsevier. Emergency Medicine Clinics is a quarterly publication consisting of review articles centered on a central topic. Today we'll be discussing a recent issue on severe sepsis care in the emergency department. Joining us now is one of the guest editors of this issue, Dr. Michael Winters from the University of Maryland. The first article I'd like to look at is Fluid Resuscitation in Severe Sepsis, which you wrote with Dr. Rob Laughlin. IVS therapy is obviously a key factor in sepsis treatment. What do physicians need to watch out for?
It's a great question, Patrick. And in terms of just fluid resuscitation, I think it forms one of the tenets of early and aggressive sepsis resuscitation. Along with early identification and early antibiotics, we want to provide patients with an adequate amount of fluids. And quite honestly, this has been a matter of intense debate over the last several years, how much fluid to give. And if we look back on the early goal-directed therapy trials specifically, patients, got a lot of fluid in that first 6 hours of resuscitation, in essence, close to about 5 liters. And since that time, we've had a number of major sepsis trials comparing that early goal-directed therapy protocol with now current usual care, and we'll get into that momentarily. But a focus of those trials also was on fluid resuscitation. So with respect to the chapter that we're talking about now, what we go through is the rationale for fluid resuscitation, why it is an important component with respect to sepsis. And then we go over the certain types of fluids. So as many of our listeners know, we can break that down into crystalloid fluids and colloid fluids. And regarding crystalloids, we can also break that down a little bit further into normal saline versus balanced solutions. And those balanced solutions, some of the examples are lactated ringers, plasma-lite are the two most common. We talk about why they may be preferred in terms of fluid resuscitation for patients with sepsis and septic shock. Much of the evidence remains observational, retrospective. We are getting some randomized controlled trials comparing the two, but we do delve into that discussion of normal saline versus balanced solutions. And we also touch on the colloid solution. So when would albumin be indicated in sepsis or fluid resuscitation for sepsis? And then why we shouldn't be using the semi-synthetics such as hydroxyethyl starch. So that in essence is what we talk about in the fluid resuscitation chapter.
Can you take us through the hemodynamic instability in septic shock?
So in terms of patients who are hemodynamically stable, it's pretty hard to determine exactly how much the individual patient will require with fluids. In terms of monitoring fluid resuscitation, what we term now fluid responsiveness or volume responsiveness, we know with the latest iteration of the Surviving Sepsis Campaign guidelines, we're moving away from markers such as central venous pressure or CVP. We've long known that there's lots of problems in using CVP to assess volume responsiveness and really moving more towards the dynamic markers of volume or fluid responsiveness, namely passive leg raise, the respiratory variation with the inferior vena cava as measured by ultrasound, things like pulse pressure variation, stroke volume variation, and a few others of the sort. But definitely a critical component in determining really when to stop giving fluids in the setting of sepsis.
How about the phases of resuscitation?
So you bring up a wonderful point there in terms of when we're giving fluids also depends specifically on the phase of resuscitation. And if you think about it, many of the patients that come into the emergency department are in that early sort of salvage phase of resuscitation. In other words, we're trying to obtain a minimal mean arterial perfusion pressure, quite frankly, to sustain life. Beyond that salvage, we get more into what's called the optimization phase of resuscitation. And that's where we're starting to use these dynamic markers of volume responsiveness to really better target the specific volume requirements, starting to prevent organ dysfunction. Beyond that salvage phase, the optimization phase, we then move in more towards the stabilization. So we're then looking to maintain euvolemia. And finally, when patients are up in the ICU, we look at what's called the de-escalation phase. So we will then start to bring volume off of patients and actually de-resuscitate or diurese them to get them back to a normal intravascular volume. But I think highlighting that doesn't mean hold off on fluids when they first hit the ED, because many are in that sort of rescue or salvage phase where they do need aggressive volume resuscitation within the first few minutes or hours of their ED course.
Next up, I'd like to look at The New Usual Care by Drs. Jared Radbill and Daniel Boutsikaris. Can you take us through some of the key takeaways in this article?
Well, I think in terms of this particular article, this chapter, it really focuses on a deep dive into the three most recent large multi-center, multinational, or international randomized controlled trials of Process, Promise, and Arise. And I think many of our listeners know and are very familiar with these studies. In essence, what they were multi-center international randomized trials to compare early goal-directed therapy as it was used in the original 2001 trial to current usual care. And the big take-home points with respect to this particular chapter is that the central tenets of usual care, what we currently do provide, or what we should be providing, is early identification of that patient who may harbor a life-threatening infection, early and aggressive fluid resuscitation, appropriate antimicrobial therapy, and then source control and maintenance of an adequate mean arterial pressure. The big take-homes, I think, in terms of those trials were that central hemodynamic monitoring. So what I mean by that specifically is the use of CVP, or central venous oxygen saturation, really didn't result in any improvements in mortality when looked at in Process, Promise, and Arise. So that's the critical take-home message. Now, I'm not saying in any way that you shouldn't be placing a central line to administer vasopressors or administer blood products in that individual patient who needs it, but the insertion of a central line simply to measure CVP or central venous oxygen saturation didn't actually result in improvements and outcomes in these latest three big trials.
Any final thoughts?
I do want to add one other thing, and that it is important to note that usual care at the time of that initial 2001 early goal-directed therapy was markedly different than what we see today. And that difference in usual care back then, patients got some antibiotics, they got a little bit of fluids, they hung out in the ED and then got admitted to the ICU. I think a huge credit goes to Dr. Rivers and his colleagues, because they really put this at the forefront of resuscitation and our care of septic patients. And really, when you look at current usual care, probably a main reason why usual care didn't result in improvements in outcomes in these three recent trials is because we've really made significant improvements in usual care, and that a lot of that can be attributed to Dr. Rivers and his colleagues.
Let's take a look at Source Identification and Source Control by Drs. Zeke P. Oliver and your guest editing partner for this issue, Dr. Jack Perkins. What are the main challenges of source identification and source control?
Well, I think source control, as we would all recognize and understand, is a critical component of successful resuscitation of a septic patient. Antimicrobials, yes, we're getting them on board, and we're getting them on board as soon as possible, and we'll talk about that momentarily. But at the end of the day, if patients have a source of infection, unless we remove that source, they're not going to get better. They're not going to improve. And so is that an empyema? Is that an intra-abdominal abscess? Could that be an indwelling intravascular catheter that's the source of their bacteremia? We have to look for those sources, and they need to be removed as soon as clinically or as feasibly possible. Now, that can take one of several routes. Certainly with respect to source control, we're not going to delay antimicrobial therapy. We're not going to delay fluid administration or resuscitation. But we do need, in many cases, to involve consultants with appropriate source control. What I would say is, in terms of the top 5 sources for sepsis, number 1 tends to be pulmonary, so pneumonia or pneumonic sources. Number 2, genitourinary. 3, intra-abdominal. 4, skin and soft tissue. And then 5, indwelling lines is typically what's taught in most textbooks and writings and readings on sepsis. So what does that mean? While you're resuscitating the septic patient, you need to be identifying the source. Is it a pneumonia? Is it an intra-abdominal abscess? Is it a gangrenous gallbladder or an appendicitis? Or is it necrotizing fasciitis? in many of those, we need to rely on surgical or interventional radiology colleagues. So early consultation, and then when the patient is hemodynamically stable and appropriate, we need to get source control done, preferably within a few hours of sepsis identification.
How often will symptoms create a false impression in regards to the source of the infection?
You bring up a great question there. And in terms of just casting a wide net or a broad net in the patient who has really septic shock, severely ill from sepsis, we want to be looking in most places. We don't simply want to rely on a chest x-ray in someone who has a cough and sepsis. We want to send that urine. We want to do a good abdominal exam to determine if there could be an intra-abdominal source. We want to look over their skin and soft tissue areas to see if there could be necrotizing infection or a bad cellulitis or abscess that needs to be drained. And we want to be looking for indwelling lines. So in someone who really this whole volume of our EM clinics in North America is dedicated to, the sicker septic patient, you got to be doing a thorough exam and considering these other sources for infection.
Lastly, I'd like to look at appropriate antibiotic therapy by Drs. Michael Allison, Emily Hale, and Brian Hayes. How crucial is the timing of antimicrobial therapy?
I would say it's probably one of the more critical interventions in treating patients with sepsis, septic shock. We know that the latest iteration of the Surviving Sepsis Campaign guidelines really has moved from not only recommending antimicrobials within the first hour for patients with septic shock, it's really now for all comers. So really soon after identifying someone with sepsis or concern for sepsis, we want to be very vigilant and getting empiric antibiotics on board. And what we say is appropriate antimicrobial therapy. So what does that really mean? Appropriate is going to be different for all of us. We practice in different settings, rural, community, inner city. We practice in different environments. And so the organisms that I see here in inner city Baltimore are going to be different than practitioners who may be practicing in the Midwest or the West, California, Washington, Florida even. What you really need to do is take a look at that particular patient. What are their comorbidities? What prior infections have they had? And with those organisms that they've had, what were those sensitivities? And then what's really your ED or hospital antibiogram? You want to target the antibiotic to make sure it's going to be effective for that patient and absolutely get it on board, preferably within the first 60 minutes of identification of sepsis.
Can you take us through the role of cultures?
It's a great question, and we absolutely, in terms of antimicrobial stewardship, want to get appropriate antibiotics so we can identify the organism and determine sensitivities. Having said that, it is important that if you are having struggles or challenges with obtaining blood cultures, that this not delay the administration of antibiotics. So we want to get those antibiotics infused and circulating in the patient ASAP. It is best practice to get blood cultures ahead of those antibiotic administration, but if it's taking too long, you really got to get those antibiotics on board.
Any last thoughts on this article?
You know, the other thing I like to say, and it's a specific point, but when we see these patients in the emergency department, we're going broad. We are going with broad-spectrum antibiotics as best we can targeted to that individual patient. Often that includes something for gram-negatives and anaerobes, and often gram-positives. And probably the most frequent antibiotic for gram-positive coverage is vancomycin. It is very important to dose vancomycin appropriately. 1 gram is not sufficient for the vast majority of patients with sepsis or septic shock. It is really weight-based. It's 15 to 20 milligrams per kilogram, and some would even up that to 25 to 30 milligrams per kilogram as an initial dose. So really pay attention to the pharmacodynamics and not only choose wisely on the antibiotic itself, but make sure you're dosing it appropriately.
Anything from the issue as a whole you would like to discuss?
Yeah, you know, Dr. Perkins and I want to thank you and EM Clinics for giving us the opportunity to really put this edition together. We're super proud of all of the chapters, and we think it really helps to bring everybody up to date with not only the current definitions and diagnosing sepsis, but what's really appropriate for, as we talked about, the new usual care, antibiotics, fluids. We have chapters in there on vasopressors. So what's the current recommended vasopressor? When do you add inotropes? And really, when do you stop? So we've got a nice chapter by John Greenwood on the endpoints of sepsis resuscitation. And then one other favorite area that I have of this chapter is we really get into special populations. So what do you do in the pediatric patient? Why is that different than the adult in terms of sepsis resuscitation? We have a great chapter on resource-limited settings. So what is optimal or best practice management for sepsis resuscitation in settings where you don't have every resource that's available at your fingertips for disposal? So we cover a whole lot, and once again, we touch on, I have a nice chapter by Jeremy Faust and Scott Weingart dedicated to the Medicare issues with SEP1 and the early management bundle for severe sepsis and septic shock. It's a key focus for many of us here in the U.S., and as we confront regulatory issues, a very provocative and thought-provoking chapter to end out this particular clinic edition on severe sepsis and septic shock. So our thanks once again for the opportunity to put together what we feel is an outstanding group of chapters on up-to-date management with severe sepsis and septic shock.
Thank you for joining us for this edition of the Emergency Medicine Clinics podcast. For an exclusive discount on this issue, focusing on severe sepsis care in the emergency department, visit us.elsevierhealth.com/EMC podcast. Emergency Medicine Clinics is available for individual print subscription with accompanying electronic access, as well as on the Elsevier electronic platforms Clinical Key and Science Direct. A CME program is also available. For more information, visit info.theclinics.com. Be sure to follow us on Twitter at eMedClinics and subscribe to the Emergency Medicine Clinics podcast on iTunes and the Google Play Store. Recent issues of Emergency Medicine Clinics have focused on observation medicine, wilderness and environmental medicine, and neurologic emergencies. Thank you, and we'll see you next time.